just started to record. Right, so what I'm hoping to do today is I've got a few crib notes here just to remind me about what I'm doing. I'm going to put up a presentation in a minute, and what I'm going to do is do it a few slides at a time to give you a chance to participate. I did think about breaking you into rooms and stuff like that, but I gotta say, because this is the first time I'm doing this, I was a bit worried I might bollocks it up, to be honest. And I don't want to lose any of you in the IT world. But also doing it this way, it feels intimate enough. And I'm hoping, being that you all sort of spoke out and said little bits about yourself, that when you're prompted to sort of contribute, please do. I mean, this is all part of the network, sharing ideas and learning from one another. Although I know a bit about self-injurious behaviour, the stuff that you might contribute is going to be, it's going to add to that and be a real help to everybody. All I ask is, don't all speak at once when we get to that point. Put your hand up and maybe I'll cue you in or whatever. I know some of you might have muted yourself because of background noise, but feel free to unmute and participate. Okay then. Oh yeah, I paid for the extra time so that we don't have, we're not limited to 40 minutes or any particular time. The only thing I would say though, if the checks bounced, the milestones checks bounced, maybe we'll be cut off after 40 minutes. Who knows? We're living in certain times. So, try and bear with me if I don't quite get it right. So what I'm going to do now is put up my presentation, or rather the first few bits of my presentation. Right, can you see that?
Yeah.
Oh, good. Well, that's a good start. Right, so what I am aspiring to do today is just go through something on the self-injurious behaviour. As you can see, I put it as types, causes, and management. Sorry, there we go. No, it's not. So the overall aim is just to give you a bit of understanding why people might self-injure and look into helpful approaches to this type of behaviour. So I've got a few objectives. So we're going to look into how self-injury, self-harm might present itself, the reasons why people might self-harm. I think this is probably the most important bit. What constitutes positive and helpful approaches to people who self-harm? And finally, because we have to pretend to care about our colleagues every now and again, how does self-harm by an individual impact on others, and what can we do to address that particular impact? So, just got a definition to share with you. So, self-injurious behaviour, any behaviour initiated by the individual which results in physical harm to that individual. And the definition goes on to give a few examples of that physical harm. Bruising, laceration, bleeding, bone fractures and breakages, and other tissue damages. I'm going to ask you in a minute whether, you get any other ideas about what self-injurious behaviour is, or other examples of self-injurious behaviour. But I also want to share this as well. This really hit home to me as a really powerful perspective, and it sort of accords with a lot of my experiences, really. So self-harming has been described as a physical expression of emotional distress. So some people find that the physical act of hurting themselves helps them deal with overwhelming emotional and psychological issues. So I'm just going to stop the presentation for a minute, just to ask you really, and this is where I want you to jabber away like nobody's business, and maybe sort of give me some examples of self-harm, instances of self-harm or types of self-harm that you have encountered in your careers. What sort of things have you got then?
We've also seen use of ligatures or ingesting inedible items.
Yeah, yeah. Who was that?
That was Emily.
Oh, right. Sorry, Emily. Yeah. Yeah. What else? What else have we got?
People biting themselves, people biting their hand,
Yeah.
that sort of thing.
Yeah.
Repeated stuff like that.
Pika, did somebody say pika? Yeah.
You also have the misuse of alcohol and drugs.
Yes. I mean, I haven't gone into that much, Tracy. I think we had a bit of a conversation about this a few years ago when I originally did this session about should we include, what's the word, self-neglect or self-harm in that sort of way. But yeah, misuse of alcohol and drugs. Yeah. Anything else?
Hitting themselves or hitting themselves in the head.
Yeah.
Head butting onto the wall or floor, and also slamming other limbs into other limbs, or one foot into another foot. Just any kind of behaviour like that, really. And
What we've had recently has been like pulling people their peg out.
Pulling their peg out. Yes. Yes, I've come across. Yeah. In my career, I've come across people doing stuff to their stoma bags or pulling catheters out. Yes, that must be quite painful, actually, the peg business. Yeah.
You also have people who will pull out their hair or eyelashes or pubic, those sort of things.
Yeah. Yeah.
Skin picking.
Sorry, who was that?
It's Tina. We've got obviously a lady who picks her skin and makes herself infected, makes her sores infected.
Yeah.
There's an obsession about seeing the doctor.
I think self-harm is one of those things which is sort of, it's really widespread, and it isn't just the high profile sort of stuff. It's like you said, picking the skin, stuff like that.
I work with a lady, just say, who excessively blows and picks her nose, and has done for many years, and it's really difficult to kind of for her to shift that behaviour. There has been some reduction, but she's perforated the nasal septum. And that it's just a real entrenched behaviour because she feels that there's fungus up there.
I was just about to ask, why does she do it? Why do you think that she does it? Is that what it is? She's got a
fixed belief that it's fungus, and then it's a vicious cycle because she'll blow and pick at it, and then the scud, obviously the skin reheals, she can't manage that sensation, she'll pick it, and there's actually a physical, there is a, skin scud, so then that reinforces it because she believes that's fungus. So we've tried all sorts. It's been difficult.
Yeah. She hasn't got a polyp, has she, Kate? Just out of interest.
No, she did have an ears, nose and throat appointment, and it was all fine. They just recommended keeping it moist, and we tried Vaseline and nose spray, and I mean,
on the scale of self-injury, it's quite sort of minor. However, it must cause a discomfort, and also it must cause a certain amount of frustration amongst the people that support her. Am I right in thinking that?
Yeah, absolutely. Yeah, and we get her out, and we're keeping her occupied is the kind of one of the best strategies, keeping her hands occupied and engaged. But it's the the middle of the night when she first wakes up in the morning. It's really difficult to stop those because she's doing it for many years.
So, so it's a pretty persistent sort of thing, is it? Anybody else got any other forms of self-injurious behaviour that they want to sort of share and talk about?
Inserting items into orifices.
Inserting items into orifice. It's something about the word orifice which always makes me smile, actually. But I know exactly what you mean. Not from my own personal experience, but yeah, that is a form of self-injurious behaviour, definitely, yeah. Anything else?
The interesting thing with that one, though, is often it's not annoying to the person, but it's the other people around them who are having to onto it that it's more of an issue for, isn't it?
I think it depends on what they're actually inserting into themselves.
Yeah,
There's a lady who would insert razor blades into her vagina, so that's not so.
Sometimes that sort of digging and things causes more mess than it causes. Yeah. So it depends who it's the issue for, isn't it? Yeah.
Yeah. Yes. And sometimes it always feels when people are inserting things, it's almost like an exploratory sort of thing. I'm just thinking back to, you know, when my children were little and they would put things in their ears and up their noses. It wasn't with any intention to harm, but it, as you said, Natasha, it sort of has the impact of harm. Yeah. Okay, then, we could go on forever about types of self-injurious behaviour, and I'm going to add to it by putting up a couple of slides with some types of self-injurious behaviour that I've identified through looking at literature. Yeah, I just want to add, you know, some of this presentation reflects my personal experience. A lot of it is, it reflects my reading as well. And there is a reference list at the end of the presentation. So I won't want you to think I've made it all up. Okay, so just bear with me. Oh gosh. Right, okay. Yeah, okay then. So lots of stuff which you mentioned already, and some of it feels a little bit alarming at times and distressing to sort of watch as well as for the person. So we've got things like head banging on walls, the floor and other surfaces, hand or arm biting, hair pulling, eye gouging, face and head slapping, hitting self with knees and wrists, skin picking and scratching, etc., pulling out your own hair, striking your face and chest with knees, eating inedible substances or even feces, self-induced vomiting, pulling out own toenails, cutting self, picking up wounds, tongue and cheek biting, kicking or hitting body parts against hard surfaces. Oh, right, okay, no spoilers. Right, hang on, no, I will go on to the next one. And it is particularly associated with people with learning disabilities. Again, I've taken this from various articles, so it reflects that specific research, but it's felt that nearly 20% of people with learning disabilities exhibit self-injurious behaviour, and that increases if you have a more severe learning disability, and it's associated with certain conditions. Lesch-Nyhan syndrome is one very specific one. Prader-Willi syndrome, again, is very specific. It's a couple of people have entered the waiting room, so let me admit them. Yeah. Sorry, I rather lost my place there. Now, what I found really surprising is that it's really associated with specifically with autism and Fragile X, which I suppose if I reflect on my career, it becomes obvious that that sort of is the case. But I never realized it was such a close sort of association with autism. It does seem to be associated more with abuse and emotional trauma, and there's an association with sensory difficulties and mobility difficulties. Right, let me just get rid of that a minute.
Is there anything in the literature around people with borderline personality disorder? Or is that linked into early trauma or PTSD?
I think, I mean, borderline personality disorder is strongly associated with trauma, isn't it, Tracy? It's one of the sort of defining risk factors, really. And I'm not sure about the yes, there is an association with borderline personality disorder. Those guys are much more likely to self-injure. Yes. Yeah.
I'm not sure. Is that one of the symptoms? One of the criteria you have? Is that one of the criteria for borderline personality disorder?
For diagnosis, yeah.
Yeah.
And whether I use BPD or emotionally unstable, whichever term is best used.
Yeah. I actually did a session on that yesterday, actually, and you know, the cogs in my brain weren't working very quickly there. But yes, self-injurious behaviour is highly associated. But that sort of cues us into the next bit, which is about why people might self-injure. So we've got the fact that it might be associated with certain conditions, but you know, again, this is really at the heart of any approaches to any challenging behaviour. But it seems even more so for self-injurious behaviour. Why do people self-injure? Sometimes self-injurious behaviour, I think people find it quite perplexing and quite difficult. I saw Kate nodding her head there. Yeah. That's it. Keep, yeah, feedback. Yeah, it's really nice. Yeah. I feel like I'm talking to the void otherwise. Well,
I think, although this isn't necessarily a reason for it, I think there's often an assumption it's for attention.
Oh, yes. Absolutely. Yeah. I mean, that crops up for a lot of sort of challenging behaviours, but I think for self-injurious behaviours, that assumption is made far more. Yeah, you see people sort of hitting their heads and you think, oh, he's doing it for attention. However, you sophisticated people probably have quite different views. So tell me, why do you think the people that you support self-injure? Any thoughts on that?
Sensory stimulation.
Sorry, Geraldine, what was that again?
Sensory stimulation.
So some form of sensory stimulation. Any more offers? I think, you know, that's...
Or sensory overload.
Sensory overload. I think that's a big one, actually. I mean, a lot of the folks that we support are on the autistic spectrum. And what's one of the things which can sort of upset people like that? Sensory overload, yes, I think that's a big one. Anything else?
It is a coping mechanism for some that they utilise it to help to regulate their emotions.
Yeah, yeah. Again, you could sort of feel that that might be related a bit to people on the autistic spectrum who might struggle with that regulation of emotions. Were you thinking of anybody in particular when you said that, Tracy? Did you have anybody in particular in mind?
There are several people that I have in mind, yes.
Yeah. Anything else? I mean, when I looked at
physical pain,
communication, so a way to get your point across. Yeah. Paul, you were about to say something?
Yeah, physical pain or illness, so if they're unwell.
Do you know what? I think that is a big one, you know, especially with people with severe disabilities. You know, I seem to have known hundreds of people who would be slapping the side of their face because they got toothache. I think sort of as an expression of pain and discomfort, I think self-injurious behaviour is used quite a lot, to be honest. Anything else? Any other thoughts about this?
I know someone said sensory stimulation, but also like linked to that, like being in an understimulating environment.
Yes.
So really bored and just left for ages. I think that can lead to it.
Bored, yes. It's the opposite of you know, the overstimulation bit, but it's just as valid as a reason, I think, why people might challenge. I think in my career, I've probably more come across people being upset by overstimulation but the understimulation is just a powerful reason, I think. Anything else? Any other thoughts?
To access tangibles, so like a cup of tea.
Yeah.
That's previously reinforced. They don't have any other way to communicate. That's what they want.
Yeah.
Seen that before.
Yeah. They may not have any words,
Mm.
and they may not have access to any other form of communication. So you know, the self-injury is a crude sort of way of trying to communicate.
Yeah.
To escape from a situation, but obviously that could be communication or overstimulation if they're not happy in the environment that they're in.
Yeah. If I hit my sort of head enough, you'll go away and leave me.
Yeah.
Or if I hit myself enough, we'll be able to leave the noisy supermarket. That sort of thing, isn't it? Yeah. Okay. Anything else?
Behaviour that started as one thing but has just carried on.
Really? Yes. I think I know where you're going with that, Geraldine. Again, have you got a specific example in mind? I can't hear you, Geraldine.
Yes, I had a gentleman who had started off with toothache, but they dealt with that, but the head banging continued.
Oh, I see. So the hitting themselves or head banging was a response to the toothache, sort of helped to just alleviate it, and it just carried on. It became like a routine part of their portfolios of behaviour. Yeah.
Yes, it took 3 years to get the dental treatment, so by then it had become habitual. That's a whole nother issue.
Yes, that's appalling. 3 years. We think how,
And what about tics?
Sorry, say that again, Tina.
What about tics?
Right, so you mean...
So you know where I'm going with that?
Involuntary sort of...
hi, Caroline.
Movements, is that the sort of thing you...
I'm all right, thank you. How's you?
Right, involuntary movements, is that the sort of thing you're thinking of? So, yeah. I mean, it's not intentional self-harm, or is it? I mean, again, are you thinking?
Well, it can PBM, because you can be tested for motor, or you can be for unmotor. So you can have both.
Let's have a look. When do you want to move it to?
Is there something in the chat that shouldn't be here?
Okay.
Sorry,
it's the 26th of October.
Josh and Beth, whoever you are, should you be in this chat room?
Or are they taking a phone call?
I'll mute them for a minute. Yeah. Okay. Yeah. Okay. Yeah. Sorry, Tina, what were you saying?
So you can be tested for motor or unmotor. So you could have tics where you can control and tics that are become of a behaviour, a learnt behaviour. So if you're ticking and you're continuously ticking is a learnt behaviour, but if it's a motor and it's untreatable, then it's a condition where you need to be treated for. So it becomes a behaviour.
I don't know. I mean, I tend to think of tics as sort of involuntary movements, and there's a whole...
always.
Right, okay.
I'm speaking from experience, it's not always.
Yeah. Well, I suppose, you know, the tics in themselves, involuntary movements can lead to harm, unintentional self-harm. I suppose rather like with Geraldine's example, it might start as just an involuntary movement, but...
Yeah, and then it becomes a behaviour.
Maybe the person has learned through the sort of involuntary movements that they will get a bit of attention. You know, I don't like to go down that road, but maybe that's a process where that might happen.
It might be just that it causes distress and they take it out on themselves.
Yeah. The tics themselves are frustrating, yeah.
Sorry, Alan. Although attention seeking is a really negative term, it's actually really valid though. Sometimes people are just asking for attention, or they have a need that is.
I think it's just the way it's framed. You know, attention seeking is just a stereotypical way of talking about it. But if you frame it as gaining necessary attention, that sort of thing, or
absolutely, yeah. It has negative connotations to it, but it can be really valid for some people.
Yeah. Okay. I feel like I want to go on to the slides now, if that's all right. Or is there anything else that anybody wants to share over reasons why?
Just quickly wondered around, so particularly with headbanging, Alan, and around kind of the release of endorphins. I think we had a supported chap with a really rare chromosomal disorder called Fried syndrome, and he pretty much hit his head almost continuously, but there was kind of, you know, it was multifunctional, but you know, there is an element of actually, for some people, the release of endorphins is one of the it's quite a powerful thing, isn't it?
Yeah. This does crop up in the literature. Yeah, I think it's a small sort of group of people, to be honest. I rather suspect it's merely to sort of cope with an unstimulating environment or overstimulating environment, or sort of indicate pain. But I think, you know, I think this is why self-injurious behaviour is a little bit complex and difficult, because there are so many sort of potential reasons. But I don't know. I'm prepared for you to sort of, you know, argue with me over this.
Yeah, I think self-injurious behaviour was associated with this rare syndrome, Fried syndrome, as well. A calcification of the brain. So it's quite complex. So it's multifunctional.
Just one other as well, Alan. I used to work with a gentleman who injured his fingertips in his hands, and it was because he couldn't feel where the end of his body was. Essentially, he was hypersensitive, so he'd do it as a sort of sensory regulation.
Okay, so he sort of needed to sort of harm himself, so he had a better understanding of his
he'd have an awareness of where his body finished, where his fingers ended.
That's very subtle, isn't it? It's hard to get your head around that, isn't it? I'm not denying it, you know, I think it's, you know, I can understand it, but, you know, I think that's you need quite a sophisticated outlook to appreciate that. What did you do to help this chap, Emily? So
we were taught some sort of deep pressure massage techniques for his fingertips.
Yeah. That's very interesting. I've never come across that before.
Tight clothing is really good for that as well. For proprioceptive disorders, tight clothing, sort of sportswear and things like that is really good. Weighted blankets, even sort of things. There's one chap I used to support. We actually put a tent in his bedroom, just a small one-man tent, and he'd go into his tent, and that helped just sort of give him a bit of understanding of where he was in the space around him as well.
Yeah.
So those are quite, there's lots of different sort of things with that sort of area.
Yeah. Great stuff. Got solutions already, responses that are helpful. I'll just go through the bit. So sorry, was that somebody?
Natasha again. I was just thinking, one thing maybe we haven't touched on is that for some people it is quite soothing.
Yeah.
Almost like I know we said emotion regulation, but someone was saying about hormones. I think there might be some evidence that like certain types of self-harming give you a sort of hormone release, like that can actually make you feel better. So it can be quite almost so it goes along with the emotion regulation thing Tracy was saying. So that can make it difficult to stop if it actually makes you feel better so effectively. Like Tracy was saying anyway.
Thank you, Natasha. I'll just put my slides up. Right. Okay, so not in any particular order, but lots of reasons why people might self-injure. So a way of communicating pain or coping with pain, an expression of poor physical health or an undiagnosed illness. I think, you know, there's real perils with people with severe disabilities who, you know, find it difficult to explain, you know, the simplest sort of illness, which may be causing a lot of discomfort. It could be a communication of anxiety, stress or fear, a way of gaining an interaction or asking for support. It could be a way, as we said, about avoiding situations or avoiding contact with others. Could be because people are in too overstimulating environment, or they're just bored because it's, you know, a drab, understimulating environment. Self-injury can lead to the release of beta endorphins, which can be quite pleasurable. It could be a protest against an activity, a way to get people to leave you alone. It could be because you're feeling frustrated because of sensory deficits. It could be related to neurological damage. It could be an expression of poor emotional well-being, mental illness. I think the thing I probably should have added to the slide, I thought I had done, was I think the impact of trauma and abuse is very powerful as a long-term cause of self-injurious behaviour. I've known several people who, you know, have been sexually abused or physically abused, and don't know for sure, but it feels like it's contributed to their enduring self-injurious behaviour. It could be due to specific disorders, which we talked about already, lack of personal control over their life. And I thought this was quite sort of interesting. Is it related a little bit to stereotypical sort of movements? So do the repeated body movements act as a sort of prototype self-injurious behaviour? I suppose I'm thinking about things, I suppose an example might be prolonged rocking might end up being something which ends up being something which is harmful because it becomes more vigorous. I've probably got that idea from a very specific study, which maybe if you wanted to track that down, you can use a reference list. Other areas where the literature suggested that self-injurious behaviour might be caused, linked to epileptic seizures, frustration about something that has gone wrong. That brings to mind to somebody that I knew years and years ago. I think he came from one of the Peel and Constable project, Farley, that sort of area. Whenever the slightest thing went wrong, and it could be like a simple thing like not being able to do his laces up, or open a milk bottle top, or put his belt on, that sort of little thing would be a cause of him hitting his head, to be honest. Because, you know, what we did was, as soon as we heard him being the slightest annoy, we intervened and sort of helped him with those little things. Again, I think, you know, quite sort of mundane things like that can be a cause of self-injurious behaviour. But it could be down to sort of long-term stuff, feelings of lack of self-worth, feelings of wanting to punish yourself. I think the whole area of the impact of traumatic life events, we know that people with learning disabilities are much more likely to have adverse life experiences than the general population. I think that is a very big sort of area. Right, okay, left over from a specific developmental stage. I can't remember what the hell that was all about, actually. Perhaps one of you might be able to think of an example of that. Or learn behaviour, a way to control the environment, sort of links in a bit about what we said before about you know, wanting to send signals to people to go away and leave me alone, that sort of thing. Okay. Yeah.
Could I just add? There's also a growing online trend. So when I worked in East Sussex last year, unfortunately, there was a kind of trend for young women young girls to self-harm by
yeah.
cutting their thighs, and it was just really sad to watch because there was no real reason why they wanted to do it. They just wanted to be part of something, and that was what was going round at the time.
Yeah, so the self-injury, it becomes like a cultural norm for that particular group, and there's an element of trying to fit into a group. Yeah, yeah, yeah. And as you said, it made you sad. It was a sad thing to sort of deal with. I think, you know, towards the end of the session, we'll talk about the impact on people supporting individuals. Did you do any work to help that group of people?
No, I not directly, because I was in adult services, but it was unfortunately a colleague's daughter who
part of
the trend.
Yeah. Lively. That was an online thing, wasn't it? What did you say? Yeah, yeah.
One of the other areas that we haven't talked about is eating disorders.
Yeah.
And the harm that causes for individuals, both men and women.
Yeah, yeah. I mean, I don't know much about eating disorders, Tracy. I mean, I don't really understand why people have eating disorders. Is there anything that you wanted to add on that and causes of those sorts of things?
Well, I think that it's just too big a subject, really, isn't it, in some respects? There again, it's multifactorial as to the reasoning behind that. That could be early trauma, it could be lots of different scenarios that are within that, but it is about body dysmorphia or whatever it's called, and you know, all of the things that come into it. So quite complicated.
Yeah.
The only thing that I can add on eating disorders is going through it myself, is that it kind of makes you feel better at the time.
Yeah. Was that eating a lot or not eating or
not eating? And obviously my daughter has an eating disorder, and it's through trauma that she had.
Yeah, yeah. So it's definitely sort of seems to be related to what Tracy said about the impact of trauma, and it's a sort of coping sort of mechanism.
Yeah, and it's about how you fit and about how you fit into society.
Yeah, yeah, yeah. Sorry, Tracy, were you about?
No, I was just saying it's about having some control over what's happening within your life, and that enables you to control something that's happening.
It's also a massive help. Cry for help.
Yeah, yeah. So maybe it's a little bit, you know, it fits in a little bit with that quote I put in earlier on about self-harm as a, you know, it's an expression of distress. Yeah.
Yeah.
It's not necessarily just a sort of response to a very sort of specific situation. It's sort of like expression of long-term distress. What about things that might be helpful? I think that would be a good thing to go on to now. Well, actually, no. Let me just show you a couple more slides. They're a bit random. The specific sort of stuff around causes. And then we'll go on to what we can do to help. So there's just a little bit, as I said, it's a bit of a random sort of section, this, because there's some research that maybe speculates are self-injury locations related to acupuncture analgesia sites. I thought this was quite interesting because, you know, it does fit in a little bit with autism. Some people may have an altered, blunted perception of pain, and that appears to come up sometimes in people with autism, having a decreased sort of sensitivity to pain and temperature. There's a bit of research that I came across where sort of noted that self-injury is more likely in certain parts of the body, and the argument there was, are those bits easier to reach, or do people harm the bits of their body which are more likely to elicit attention and support? I just leave you to sort of track down the article on that. That was interesting though, because I suppose my initial thoughts were that somebody with a severe disability would tend to sort of harm themselves in the places that are easier to reach, but somebody with a greater intellectual capacity, they will go for more visible places because they want to, you know, it's a conscious cry for help. And there's a whole thing about learned behaviour. So how people learn self-injurious behaviour because they've been exposed to it, or examples of it. I put the long-stay institutions because I suppose that's it's something which resonates with my career, but I rather suspect, you know, there's other contexts where that could have happened. Again, just a very bit specific sort of bit of research that there's 4 medical conditions that this study identified: the urinary incontinence, visual impairment, cerebral palsy, plus pain and sleep disturbances were particularly sort of predicators, is that the right word? Predictors, perhaps, of self-injurious behaviour. Not exclusively so, but those seem to be quite sort of important sort of factors. I've just thrown that in just to sort of, for the sake of completeness, really, so that, you know, you'd have access to those ideas, really. And also sort of, I mean, I think this is a little bit from my own personal experience and a little bit from the research. I do have a bit of a passion about this subject, that medical causes, pain and discomfort, particularly for people with severe learning disabilities, are going to make you likely to harm yourself, to try and either alleviate the pain and discomfort or to alert people that something's wrong. So there's just a few ideas here about, you know, gastrointestinal disease, urinary tract infections, hormonal changes, but I sort of think that what are quite mundane things like headache, migraines, toothache, chest infections, cold, flu, I think those are highly implicated in the,
and it's very difficult, isn't it, Alan, when you've got somebody who may hit their head, because actually that will cause the headache, but they'll continue to hit the head because of the pain. So it's a vicious cycle, really.
It can be, yeah. But I just think, you know, I think we've got such a duty to sort of try and you know, be vigilant about this. Yeah. Particularly self-injurious behaviour suddenly sort of starts when you haven't really sort of observed it before. That's the first thing I'd be thinking of, to be honest. Maybe that's my nursing background, who knows?
No, I think that's something that we all do, that we have to look at, is there a physical cause? And then go on to more sort of the emotional and sort of psychological impact as well, especially if they're presenting with significant challenges. So
just checking on the time. Are we all right? Are we all right to carry on? I'm just aware that Zoom can be a bit tiring, actually. So I'm willing to offer you a break, but I'm equally willing for us to carry on, if that's all right. What do you want? Who would like to carry on? Put your hands up if you want to carry on. Oh God, I can't count. I've run out of fingers and toes. Anybody would like a break? Anybody particular would like a break? Oh, nobody's saying anything for that. So let's carry on. Okay, so over to you guys again. What would be nice if you were to sort of tell me helpful stuff? I've got a few slides with helpful ideas on them, lots of helpful ideas, but You know, you can be as specific as you want. Obviously, you're bearing in mind confidentiality and, you know, going through somebody's story. But, you know, sometimes the specific examples, you know, lead to ideas which have a lot of general application. So what's your views on that then? What ideas have you found helpful?
It's often around harm reduction, isn't it? So,
yeah.
I think we had one patient when he was hitting his head, we were using soft pillows and we've used the small peanut ball. So still able to do, you know, hit his head and get that sensory feedback to a degree, but it's just, reducing the risk and the harm.
Yeah, that's a little bit of a PBS thing, isn't it, really? You know, altering the environment, making the environment safe.
Yeah.
I guess you could have things like making sure you haven't got windows that will break easily because somebody has a habit of breaking windows and then cutting themselves, those sorts of things, yeah. Thank you, Kate. Right. Anything else? There must be loads of ideas that you've got.
I mean, I think individuals start to look at their own coping mechanisms and you support and help them to look at that and whether there's an alternative to them actually, you know, doing the self-harm. So you're offering some alternatives to and helping them to put those into a practice, really.
Yeah. So finding an alternative behaviour on activity so the person...
And validating how people are feeling and enabling people to know that you are with them, you understand it's not, and I think there's a lot of debate around the self-harm, especially around emotionally unstable personality, that you should stop it. Now, the more that you try to stop it, the more an individual is likely to find something to harm themselves with. So it's about working with it and recognizing that there will be risks and those risks will have to take place, but you try to minimize and build up trust and hopefully that the individual will feel in a better place to minimize the amount of time that they self-harm.
Sure, you can to sort of, you know, keep the environment safe, but it's very difficult. I mean, as soon as you think in terms of stopping something, you're starting to get into almost like a punitive or authoritarian sort of mindset, where you want a little bit more, as what you said, Tracy, more understanding and trust building sort of mindset. What else? What other ideas have people got about helping people who self-harm?
I suppose building on communication skills is really important, or providing alternatives. If that's going to be part of the cause.
So giving people, if people have no words, giving people alternative ways to communicate, helping people learn new ways of communicating.
And as well, giving people information so that they understand what's happening. Like if the self-harm, like, you know, I was saying about people putting their peg out, giving them really understandable information of why they have the peg or the stone bag. Some people have these things happen to them and then they're picking their bandage off or they're doing those things, but if they understood why it was happening, it'd be a lot less distressing. That goes
I think as well, increasing like their sort of meaningful daily activities, so they're doing more for themselves and probably got a little bit less time or got more of a focus.
So for those people for whom boredom is a trigger or potential cause of self-harm, making sure people have got a structured and meaningful sort of activities. Is that the sort of thing you were thinking of, Naomi? Yeah. Anything else?
The response is really going to depend on the function, though, isn't it? Depending on what the function is for that person, you could have. You could have the same behaviour in two people with completely different functions. So how you respond will be completely different.
I think it's just trying to find, you know, we've all experienced self-harm or self-injury with a number of individuals, and it's just trying to share what the strategies that we've come up against or try to implement with individuals or support them to feel more in control of their lives, really. So I think you're very right. It is very individual, but there are some common themes across, because we've probably all supported individuals in a similar way.
Yeah, yeah. I think, you know, finding the function is really key, because what Naomi proposed for the person who's bored really wouldn't work at all with the person who might need a more low arousal, less stimulating sort of environment. I think sort of just generally giving people more control, as you suggested, Tracy, is a big part of
Sometimes that's difficult, Alan, especially if you have an individual who has a severe learning disability and significant communication difficulties.
Yeah.
So, you know, it's trial and error sometimes, because there won't always be a particular way or a specific function, and it's very hard to understand that function. And you will have to, you know, through trial and error. There are times where we have used PRM medication just as a preventative measure to prevent it from getting any worse, because that person's in a distressed state. Now, whether that's right or not, it's very difficult, but that's what we tend to do, or we try to work out, is that a better option than actually them harming themselves to the degree that they might need treatment?
I think there's some general sort of considerations there. I think one is they need to be pragmatic and try different things, even if, you know, some of it might not feel, you know, we're all very keen, for example, not to over-medicate people. However, if the reason why somebody is self-harming because they are so very anxious, it feels appropriate. And also, I think, you know, again, a PBS principle, the need for a long-term approach. You know, that you need to sort of try things, and when you hit on the you know, the best solution, it might not be a perfect solution, and it might mean that the self-injurious behaviour is reduced rather than eliminated completely. You've got to apply it consistently for a long term. So I think, you know, I don't think I put those points on the slide, but maybe they just seem too obvious. But we don't always do the obvious, I think. You know, I think self-injurious behaviour can sort of flummox people a bit, and you know, they get rather caught into inaction rather than being proactive. What else? Any other thoughts?
I think a big thing I end up working on is the staff response to the self-injurious behaviour. Do you get involved?
Yes.
Do you basically say people stop doing that? You know, like Tracy was saying, do you stop them doing it, or do you let them do it? People, I know you're going to talk about in a minute, people get very distressed watching it, so they want to get involved. They want to hold people's arm, and it's, oh, what move can we use when they do this? And it's really changing those responses, isn't it?
But it's also around the perception that you have that if, and we've experienced it, and Emily can talk about this, and Sarah can talk about it a lot, is that we have an individual who self-harms quite regularly, or has in the past regularly self-harmed, has needed hospital treatment, and then the staff there sort of look at you as if to say, how do you let this happen? And actually, you can't just stop it from happening. You know, you take things out of the environment. Along with the person's consent, we remove any sharp objects, any potential objects, and it could be anything. So they've got quite a barren sort of home, but it's for their own safety and it's with their consent. But if they didn't consent, what do we do then? And, you know, it's the perception of others as well. And I think staff, and especially in social care, staff have a lot to deal with, an awful lot, and there's no recognition of that really.
Because we have a duty.
It's very cyclical as well, isn't it? Sorry, Alan. It's quite cyclical. So we'll find with that individual that there'll be periods of time when they're very settled and they manage their self-injurious behaviour very well. And then as soon as it starts, that feeling of self-worth declines. They feel bad that it's happened, and I think that feeds into further feelings and further incidents of self-harm. So it can be quite intense at times with that individual.
So perhaps part of the solution is how we care for our colleagues and one another through this sort of, that feels like anything which helps us, we who are supporting individuals, is going to help the person that is self-injuring.
Yeah, I think you're absolutely right, and especially for the team that have been working with the individual, it's about just reinforcing with them, revalidating with them that they are doing everything that they possibly can, and you know,
and working with other teams as well outside of the home. So we've had to link in and do a lot of work with local district nurses. We've met with the South West ambulance teams, linking more closely with the GP now. So it's not just you know, supporting the staff team, but we've had to make sure we've got a continuous multidisciplinary approach around it, really.
Yeah. Anything else? Any other thoughts about, you know, what is helpful to support people and help to sort of minimise self-injurious behaviour?
I think generally checking in with the person and having regular updates on the risk assessments and care plans are massive. Because obviously things change daily, weekly, monthly, and how they're generally feeling and who they can go to, who they feel that supports them, not the best because that's the wrong word, but who supports them and who will follow on what their needs are.
So it feels, again, it's trying to empower the person. Is that the sort of thing? And make sure that they've got a voice, you know, that they're at the heart.
And that they understand that if they need help, that we're here and they can always come to us before they hit crisis.
So that's part of the portfolio of coping mechanisms. Rather than resort to challenge the self-injurious behaviour, you know, you give them an idea of what they could do instead, which is, you know, find somebody to talk.
Yeah, well, there's also alternative things like adversarial therapy and other therapies like music therapy and stuff like that, just taking them away from what they're currently feeling.
So
temporary fix, but it's a bit of something.
And maybe that might help people to learn relaxation sort of skills as well.
Sit down with them and go through their risk assessment with them and ask them if there's anything else they want to be added into it, anything that could make them feel better, how we could support them better, or, you know, involve the person in their package, as I call it.
Yeah, that's really important. One of the gentlemen that we support who has a risk of ligature, you know, his talk time with the staff and him telling us what support he wants in those periods. So does he want more regular checks throughout the night, or does he want to have a conversation with a set person, you know, on a day? It's just listening to him and what he wants really is really important.
That's what we've done, Emily, and it seems to work a bit better than just generally anybody going in.
Sorry, Tina, I didn't quite catch that. What? Yeah, my hearing aids greyed out a bit then. What did you say then?
I said I agreed with Emily on the check-in and the involving the person, because it helps that if somebody's in there and they don't understand the person, they could be potentially a trigger, or they could potentially not understand what they're talking about. So if you do that consistency with the same person, then they could follow it on through the communication through the team.
Yeah, so ensuring consistency of communication within the team, awareness of triggers, that sort of thing, and a bit of coaching from colleagues about an individual's communication style. Is that the sort of thing you meant?
Yeah, we all deal with stuff differently. We all deal with traumas differently. But I think when you're involved in a real situation and you work with it, it makes you feel like, I don't know, you understand them better.
Yeah.
But I think there needs to be a hell of a lot more training around everything, not just certain things.
Yeah.
A bit of a bit of an outside of the box one, and we never actually went ahead and did it, but there were some discussions at one point about a gentleman that cuts and gouges self-injurious behaviour, whether we would look at giving him ice cubes with red food colouring in so that he could squeeze those and still have that visual sensation of the red welling up, so whether it would meet that function in a different manner. So we sort of had some talks about, you know, what the function is and whether we could meet that sensory input in a different way.
It may be out of the box, but I get it, Emily. You know, I think it's part of, you know, not just being pragmatic, but creative as well. Yeah.
I think you're
He
right
didn't want to do it in the end.
You didn't? No.
No, he wasn't interested, but we did.
No.
It was something we talked about.
It didn't quite meet the function for this particular person. But it's not inconceivable that it might be helpful for somebody else, though, definitely. Anything else? Any other thoughts about what is helpful?
Yeah, I think you're right about it being a long-term plan. I used to work with a couple of women who had been sort of institutionalised, but had kind of had a history of trauma. So, I mean, we had to have a plan that not only was reactive for the actual behaviour, but also a long-term plan to sort of build up their self-esteem.
Yeah.
And deal with their emotions over a longer period before, you know, to tackle it over a longer period of time. And over time, it did reduce. It never went away, but that was part of their personality disorder. But, you know, we just did, we reduced it, and we found ways for them to do it in a sort of safer way.
Yeah. Yeah. Just thinking back to a lot of people I know, sort of like almost were punishing themselves, had a really low opinion of themselves. There's just no way you could sort of address that in days, weeks, or months, or years. I was doing exactly what you said, Geraldine, in building up trust and building up their sense of self-confidence and their sense of purpose. I know it sounds very utopian, but I bet we've all done that with individuals. Anything else? Anything else anybody wants to share on what is helpful before I go on to the slides?
I think similarly to that last point, if the function is low self-worth, the importance of enthusiastic, engaged, actually supportive support. You know, when staff are going in to visit an individual first thing in the morning, the importance of a smile and a warm body language, and to make that person feel like you're really happy and honoured to be in their presence and in their space.
Yeah. Very true, Anna. The other thing I would add to that is, you know, I think sometimes we've got to show warmth and feeling to individuals in different ways, because, you know, some people like a really exuberant sort of approach. Other people, it's got to be a little bit more low key. But I get exactly what you mean. You know, avoiding having any punitive or confrontational or negative sort of approaches. I think that is really important. And I think sometimes, you know, when we're supporting people who are any form of enduring challenging behaviour, but particularly self-injurious behaviour, it can wear you down a bit, and that negativity can come through. And I think what you said is about sort of being consciously correcting that, or being very self-aware about how we're coming across, and compensating. That's the word I meant, compensating for the negativity.
I completely agree with Anna. And it doesn't necessarily have to be that you're not showing a negative or punitive outlook. Just sometimes if people, you know, if you're walking into somebody's flat and you're blasé about it, or it feels to that person like you're just there to do a job, you know, oh, you know, I'm with you today and we've got all these things that we've got to do, and I'm here because it's my work. Well, then that person's going to feel pretty rubbish about themselves. About making them feel that actually you want to be there, you want to be spending time with them, and they're important to you, and that, you know, they've got an important role.
Yeah, I think you're quite right, Emily. I've got Tina, that lady that you support up at where you work. I bet you have to do that, don't you? That lady who shows a lot of lack of self-worth, self-confidence. She thrives on that sort of approach that Emily's just described and Anna's just described. Am I right?
Also, it's from a manager's perspective, it's really important for the right people with the right people. So some service users really get on with other people, and some really hate other people. And I mean, if someone's in a really low point, it is important to make sure that you've got a staff member who can jolly them along, or really work with them in a way that suits them better. perhaps more than on a normal day or a day where they might be in a much better place. Yeah.
So it's about being flexible and acknowledging some people need to be supported by a very specific team member. Is that
and consistency as well? Yeah. So obviously consistency in team is important, and everyone working within the same kind of ways. But you're always going to have individuals who, let's say, more experienced, or have a better understanding around that person, or just connect better with the individual. And having someone that they like come in is definitely more of a positive than a stranger who still knows what they're doing. Just
Okay. Right, I'm going to move on to the.
Oh, sorry.
Oh, sorry, one more.
Just really quickly, just the post support as well, post incident support, which should obviously be the PBS plan. You know, how long do you leave it to offer a debrief? Is a debrief beneficial? Do they want to be on their own? And kind of helping them be part of the, you know, if there's a wound, do they want to help dress it? Do they want to learn those skills? Just learning the best way, you know, what support do they want post incident? Really, I think is equally important.
Yeah, definitely.
Yeah, because it could be an opportunity to learn new stuff as well, I think.
Yeah.
I think sometimes because we don't always do structured debriefing with the people we support, we miss opportunities, definitely.
Yeah.
Right, I'm just going to put up the slides now. Okay, so I've banged on enough about the need to rule out medical or dental causes, so I won't say any more on that. Like with any challenging behaviour, you know, trying to discover the function of it is key, but I think you just got to acknowledge it could be one of so many different things, so it implies a lot of data collection and triangulation using observations and stuff like that. We talked already about developing communication skills. For some people, increasing structure and routine might be helpful, both to provide activity and also provide predictability of activity. Providing sensory opportunities or physical exercise, rewarding for appropriate behaviours. I mean, that's a little bit sort of PBS speak, isn't it? But I suppose what I mean is, most of the time, people aren't behaving in an unreasonable way, and we miss opportunities then to, you know, to praise people and commend them for what they're doing, and that's all it is. I'm not, by reward, I don't mean give them a fiver or a Mars bar or something like that. Just, you know, praise and warmth for pretty much the roles we've worked for most people. Keeping environments safe, definitely. Responding promptly. We've gone back to what I said about the chap that I supported all those years ago. When he first came to us, we were advised, if he starts hitting himself, just ignore him. It'll stop. He's doing it for attention. Classic. But we found out that because the function of behaviour was an expression of frustration, because he couldn't do simple things like open the milk bottle top sometimes, or that sort of thing, we turned it round and we responded as soon as we could, promptly. So I think that's what I mean by that. I think generally as a default, a calm and low arousal approach is good, especially bearing in mind a lot of the folks that we support are on the autistic spectrum and are more likely to have self-injurious behaviour. Making sure that we don't overload people with demands. Sometimes the trigger is sensory input. Oh, it's a little bit jargonistic, this phrase. I apologise for that. Remove or reduce unpleasant sensory input. Well, that comes down to, is the place noisy, or is there too much light, or too much commotion? Sometimes it's helpful to gain people's attention by the use of their name and a simple sentence. sometimes if you find an activity that is incompatible with the self-injurious behaviour perpetuating, that can be helpful. This isn't an exhaustive list, of course, and it's but it is taken generally from literature. The stuff about how you can mitigate harm, so placing barriers, providing soft surfaces, giving things, alternative things for them to bite on. There's a little bit in the literature about mechanical and physical restraints, but you can tell I'm not very keen on them because they're at the end of the slide. Prompt treatment for serious injury, and medication does have its place. If it's, you know, if anxiety is the underlying factor, medication which specifically address that, I think is absolutely legitimate thing to use. Right, okay. I mean, that, is there anything that you want to add, having read, you know, those ideas on the slide? As I said, it's not exhaustive, and if you go into the literature, especially more recent stuff, you'll probably find a little bit more that is helpful. Is there anything you want to add before we go on to the final topic on helpful strategies? Well, that's a big fat no. So let's go on to a subject which you will talk about, and that is how does supporting somebody with self-injurious behaviour make you feel, and also what have you done that you found is helpful for your own sort of self-care and the care of your colleagues? So, you know, anybody got any thoughts on that? How does it make you feel? What can you do to sort of mitigate the impact of self-injurious behaviour on your own well-being and your colleagues as well?
For me, it's that MDT working. It's having like the MDT working, so it's having everyone involved, particularly the patient where possible, and family, ensure, you know, particularly when there are high risks, you know, ensuring there's, you know, everyone's around the table together, particularly medic, looking at the risks, everyone's kind of jointly aware, and, you know, if you're making a plan, you know, how far, if you think about harm reduction, if we are allowing them to self-harm to a certain degree before intervention, you know, it's making sure everyone's in agreement, so it doesn't feel like it's just your responsibility, because it is a, you know, when the risks are high, it does feel like you want to jump in and prevent them, and it can be a scary, responsible type of feeling.
Responsibility being shared, and having clear plans. That seems to be what you're saying. Yeah. Sorry, Tracy.
I think it is about being able to talk openly about it, and different people will cope in different ways, and it's recognising that and working with everyone around how they cope with it, and whether that's through supervision, debriefs, or prior to, within briefings or key worker meeting, or whatever it is. There needs to be some opportunity to say how you're feeling and what it feels like, and that it's okay to feel like that. So it's not easy. There's nothing's going to be easy, because you can't just eradicate it.
I think self-injurious behaviour does promote very strong feelings. There's a bit of research on that. I mean, what sort of feelings have you felt sometimes when you've been supporting somebody who's, you know, persistently self-injured over a period of time? I mean, you know, be honest. Anything in particular? I mean, somebody said, I think it was Geraldine, said about feeling sad, you know, in relation to the young ladies that were cutting themselves. Any other feelings that you might have?
Frustration when the behaviour doesn't reduce as quickly as you'd like it to, perhaps.
Yes. Absolutely, Kate. Yes. Anything else? Anybody ever feel angry with the person that they're supporting? Or frightened?
It's exhausting because you
yeah.
put all your effort into trying to eliminate triggers, trying to ensure that the environment is safe, trying to ensure that everything around them is safe, and it's exhausting. It is. And we recently had a chap. He's 2 to 1 and was having certain behaviours and causing harm to himself and others, and we got the team together so that they could have a debrief together, just to show that obviously they've got their own support networks as well as like seniors and managers, but because it is tiring, it's really tiring.
Yeah, I absolutely relate to that, Addie. You know, physically and mentally tiring, and you know, in care and support work, you need so much stamina, just generally, you know, for enduring challenging behaviour and sort.
Absolutely.
So yeah.
I think one of the key things is not trying to take it personally, because it's personal to you. It's about where the individual's at and what's happening for the individual. They're not doing it to get to you. So I think some staff feel it is personal to them because it's about the support that they provide and it's not working. So it's all about, if we did something different, then it might be different, or they're doing that because of. So
yeah, I think sort of training around attributions and, you know, just generally have understanding about, you know, the difficulties somebody might have had in their life, I think is really important. But I've done quite a bit on, you know, trauma-informed support with a couple of the teams for Milestones, and just knowing about the difficulties that people might have had in the past is a real eye-opener. And what it means is that people are just that much more empathic, and they're less likely to go to that, you know, personalising it and thinking that it's, you know, the behaviour is aimed at them. So again, sounds very utopian, but I feel that it's really helpful. The more people know about the people's conditions and the reasons why they might self-harm, it's a win-win.
Real life.
Yeah, I think it really helps with the empathy sort of quotient, definitely. Is that a real phrase, empathy quotient? Well, it is now.
It is now.
Yeah. Feel free to use it. Anything else? Any other thoughts about, you know, things that you might have and what is helpful?
I think coming to the realization that you might not eradicate it completely, I think for me was a big one. I think, you know, you instantly think, right, we've got to support this patient. There's got to be something, we've got to help them, completely get rid of this behavior. But actually, when you realize, okay, there's only, it's that harm reduction, like I keep saying, it's
I mean,
you might not completely go, but
we aspire to sort of get into the point where behaviours are eliminated, but, you know, not sort of beating ourselves up.
Not everybody who self-harms want to eradicate it. I mean, it's part of their coping mechanism, and it's what they hold on to. So they might minimise it, but not want to actually get rid of it completely. And, you know, again, it's up to them in some respects for those individuals who have an understanding of what it is that they're doing and why they do it.
It could be also more harmful to eradicate it completely, because we've got a young lady who picks her skin, and that's apparently is quite common with the health condition. And so what we did, we got small pieces of fabric so that she could, just because she quite likes sort of like the delicateness of being able to pick something. So we got that, but obviously you can't be with certain people 24/7, and that is quite intrusive if you are. And then a person could like try and do it in a more sneaky way, or it could be that they go out their way and cause more harm. So it could be more harmful to eradicate it completely as well. So even though you don't want the people you support to hurt themselves, it could be more harmful also, and it's just bearing that in mind.
Also, you would end up with an unmet need, wouldn't you? Because the behaviour is meeting a need of some description. So you would end up with an unmet need, and that need's got to be fulfilled somewhere. So you can't eradicate it. You just have to find, like you say, reduce the harm or find an alternative.
Yeah.
I used to also work with a lady who headbutts surfaces, and the alternative was because she got that sort of release of she was so frustrated she needed to release it, so then we got her to sort of get a pillow. So as soon as she started to feel that frustration, she would get a pillow and hit her head on the pillow, and then that released that, and then that worked really, really well. Obviously it doesn't, things like that don't work all the time, but she still has that need, but she's got an alternative just to make sure she doesn't cause herself serious harm as well.
Yeah. I sort of feel that one of the feelings that we might have is that feeling that of a burden of responsibility, especially with people like you described, where, you know, sometimes they might need to self-harm, or we just cannot sort of eliminate it completely. And I feel that the burden of responsibility can be burdensome and worrying. So I think having clear documentation is very helpful. So, you know, especially because people might feel, you know, they might be held to account because somebody is self-injuring, or they might feel that they're failing. Yeah, I think that's probably another sort of feeling that people might have, feeling that they're letting the person down, they're failing. Yeah. They're not doing as much as they could, but maybe having the clear documentation and also clear sort of data collection to sort of reassure yourself that things are getting better. It might have not gone away completely, but, you know, figures are very helpful, I think, in that, you know, okay, maybe they have injured themselves 5 times this week, but look, 4 months ago it was 32 times. You know, I think that is helpful, and it helps people feel that they're making progress, and also demonstrates, you know, that we're doing our job. Anything else on the support for staff? Shall I go on to the slides? The last few slides. Hooray, everybody says. Bloody Alan Nuttall with his slides, and he didn't half go on. Right, okay. Right, so I think I probably took this from the study that Bromley and Emerson did years and years ago, and there's been other sorts of stuff that have been produced over the years, but I sort of think, you know, as well as the obvious stuff like fear, annoyance, feeling sad, you know, I think to guard against is a feeling of helplessness, hopelessness, powerlessness. I think that's quite a likely thing if you're supporting people with self-injurious behaviour. And there really is a potentiality for burnout. And sometimes you have to, you know, staff sometimes have quite unsophisticated approaches. They feel that the self-injurious behaviour is caused by factors within the individual, but beyond the control of that individual. And so what can you do about it? You know, the answer for that would be nothing, wouldn't it, in that view? So trying to sort of counteract that potential negativity and inaction, and to get people to look beyond short-term and transitory sort of factors, and bear in mind the long-term setting conditions around exposure to abuse, loss, traumatic life events. So there's a little bit about burnout here, which I won't go through because it's a bit depressing. You can read it again on the slide, but it is a real phenomenon. And self-injurious behaviour seems to be a challenge of behaviour which is more likely to predicate burnout. So what helps? So, and again, I've put in a few personal things here. I really do believe if we help people to understand that the reason why people self-injury due to specific conditions and specific aspects of their histories, it does mean they've got a far more sophisticated understanding of the person and less likely to attribute to personal reasons. So understanding why individuals self-harm, having awareness of your own potential emotions, responses and attributions, policing yourself, really, having effective responses, so something which actually addresses the behaviour, and regular care plan review. All this has come up in our discussions, I know, but it's really fundamental stuff. I think care plan review, which celebrates successes as well, I think is really important. Shared responsibilities within the team and the multidisciplinary team. Regular and sensitive supervision. By that I think I mean supervision which is acknowledges these emotions. Pragmatically, opportunities for breaks and time out from working with an individual. Effective post-incident support for staff. So that could be the sort of emotional support, I think critical incident analysis, the debriefing after events to try and work out why an incident happened, why that specific self-injurious behaviour happened, I think is really important. And I think I would add to that, debriefing with the person we support, giving them opportunities to learn new sort of ways of expressing themselves. Knowledge that we all go through difficult periods at times, and often that relates to stuff in our personal life. So acknowledging that and tailoring our support to vulnerable team members and providing peer support. It's not just around managers and other professional staff providing the support. I think peer support is very important. And opportunities for counselling. That could be formal with an external counsellor, but I guess you know, by counselling I'm using it in a very broad sense of giving people opportunities to talk and their feelings, and we can all listen to one another in these circumstances. And the last few slides are a few references, and not complete sort of stuff, but enough for you to be going on with. I never updated these, so there's not many recent ones. I'll leave you guys to sort of be inspired by this and seek your own reading. So that's it, folks, really. I mean, is there any other thoughts that you wanted to share before we end the session? It's still recording, so it will be made available, presumably, on our website when I work out how to, you know, upload it, onto our Facebook page. Certainly the presentation could be made available. I could email it to you if you want, and we could certainly put it on both the Facebook page and the website. So that's really it, to be honest, unless anybody's got anything else they want to add.
No, that's been really good. Thank you.
Thank you, Kate. Thank you. I wouldn't say I was apprehensive about this, but I did think, oh God, I hope they don't give me a hard time. The people there like Tracy Cox and Tina Yee, and my goodness me, out to give me a hard time.
Thank you, Alex. It was amazing.
Yeah, thank you very much. So I will not seek any more compliments. My head will expand out of this screen like this. So I'm going to bring it to an end now, and I think I probably will. I will send the presentation to you, and look out for the film version on the website. Okay.
If you speak to Wendy, Wendy will be able to put it on the website for you.
Yeah. It just finds in a way, it's probably quite a big file this. I'll just have to work it out, but I will sort it out. So, yeah.
Okay.
Okay, thank you very much, everybody.
Thank you.
Thanks for participating.